Hey everybody, Mr. Toda here. Welcome back to another flipped lesson, and in this lesson for emergency medicine, we'll be doing part two of our patient assessment. All right, these are our key terms here and objectives, so make sure you know these for this video, and go back, take a screenshot now, go back at the end, make sure you know them. All right, so just a quick recap, right? In our first video of patient assessment, we talked about really the first two steps. And we talked about patient assessment as a method, right, for a systematic method for finding out what's going on with our patients, what's wrong, right? I think it's the most important skill because if we don't know what's wrong with our patient, we can't treat them for that specific injury or illness. And we said in the first part of our first flipped lesson, the scene size up comes first, right? Making sure we have our BSI on, the scene is safe. We're going to do that quick, kind of get a brief picture of what's going on in that scene size up. It starts with our dispatch, our radio call, and it goes down to when we actually start to assess the patient, right? We use the acronym LISA. It should take about 30 seconds or so to do a quick scene size up. Then we got into our primary assessment, right? The A or B, A, B, C, D, E's, okay? Bleeding, airway, breathing, circulation, disability, and expose. All right, so that was our primary assessment, which takes about 2 minutes, and that's where we cover any major life-threatening issues. And in today's video, we're going to pick up here with the secondary assessment, which is, we'll talk about it in a second here, but if you think about it, for the scene size up in the primary, we've stabilized any life-threatening issues. Someone's going to kill you really quick, or someone's even going to kill you in the next couple minutes, like you're not breathing, you don't have a patent airway, things like that. And now we're going to talk about that secondary, so getting deeper. All right, and let's talk about it here. So the purpose of the secondary assessment is to obtain more information about the problem that's going on with the patient. We perform a more thorough physical assessment, right? So we're really diving deep into what's going on today. That primary and scene size up in total takes about 2.5, 3 minutes. So now we're going to use the rest of that time to get really, really deep. And the secondary assessment, doing a really good secondary assessment and getting a good patient history is key to our patient assessment and really finding out what's going on. In that primary assessment, we got rid of the life threats. We have a brief idea, oh, they have chest pain, or, oh, they're really having trouble breathing. But now what's causing that? Okay, and there's three major parts here. The first, and probably they're all very important, but first one to get out of the way is a patient history. All right, then we're going to always take vital signs, and then we have a physical exam. All right, you can see, like, here's a great picture of some different vital signs right here that are key. All right, we see people documenting, taking a history, and we see doing physical exam and vital signs. So really the three important parts of a secondary assessment. And it's important to remember, right? We might get this information for the secondary assessment, especially for the history, right? We might get that from the patient, hopefully, but a lot of times we may not be able to get that from the patient if they're unresponsive, or maybe they have an altered mental status. They're not really sure what's going on, and they can't even tell us what's wrong or what medications they take. So we might have to get it from patient's family and friends, from bystanders who saw what happened, if it's like some sort of accident or injury, or maybe they saw the patient acting funny before they went unresponsive. Might have to get it from the scene. We see this a lot when we go into people's houses where they're unresponsive for their altered mental status. We need to kind of be like investigators and look around, look on the fridge, look on the table for medications, those little pill boxes that lots of older people have. So really being investigative. And it's important too to like use our other resources. If PD's on the scene, use them to help have them kind of look around for some information as well. So that's what the secondary assessment is as a whole. So let's jump into the parts here. All right. And really one of the crucial things to get right out of the way is taking a history. And we call it a sample history. It's one of our mnemonic acronyms there. All right. And history, getting a patient history is crucial to figuring out what's going on. With most of the time, I would say 85% of our medical calls, the patient has some pre-existing condition, something that's going on. They know that they have high blood pressure, or they know that they have chest pain frequently, or maybe they had a heart attack, or maybe they have a history of a stroke or high cholesterol, right? They're diabetic, they have asthma. Getting this history right out of the way as soon as we can is key, because it's going to clue us into what's going on now, hopefully. And again, we say patient assessment, we learn it in step by step so we don't miss anything. And I say all the time, as you do more real patient assessments and you practice this, you kind of can start to blend things together. And this is one of those things where in real life, right, the history taking, it's not really in the secondary. We're kind of doing that as we're doing airway and breathing simultaneously. But for right now, we're learning this as the first part of the secondary assessment. So why is it important to do history first? Because you don't know when that patient's going to go unresponsive or start to have altered mental status. They might get confused. So you really want to try and get this done as soon as possible because A, they might go unresponsive and you can't get answers, but B, because it really is going to, again, clue us into what's going on. All right. So two acronyms here. So sample is the history, right? And let's just walk through it. Sign, and we'll go more in depth in class here, but signs and symptoms is S. And something to differentiate here. A sign, think about like a stop sign, you see it. A sign is something you see. A symptom is something the patient tells us. So a sign would be, ooh, you're really sweaty. A symptom would be, oh, I feel nauseous, right? I can't see nausea. I can't see chest pain, but a patient could tell me that. That's a symptom, all right? I might see sweating or pale skin color or something like that, but I can't see that somebody's dizzy or nauseous, okay? A, allergies. So is the patient allergic to anything? Big here, especially when we're talking about allergic reactions, but just in general, right? Do they have any allergies that may be upsetting them, that might be causing something? Do they have any allergies to medications? Good to know before we go to the hospital. And then M, medications. So what medications do they take? And you'll see a lot as people get older, right? They get more and more medications, and sometimes we have lists that are just huge, 15 medications on a list. So make sure you get all those. And important things to ask too is, did you take them today? Have you been taking them regularly? And if you don't know what a medication does, always ask. Okay. P, past medical history. I always like to say, what do you see your doctor for? Or what kind of medical history do you have? And give them some examples too. Say, oh, do you have any cardiac history? Do you have any chest pain history? Do you have any diabetic issues? You can name some too to try and help stir them up. And just say, what do you see your doctor for regularly? L, last oral intake. So the last thing you ate or drank, I had a peanut butter and jelly sandwich. Oh, well, turns out I found out in allergies I'm allergic to peanut butter. Probably not the best. All right. And then events leading up to the incident, E. So what was going on when this happened, right? I was driving my car and I got all of a sudden I passed out and then woke up and I drove into a tree. All right. So E, events leading up to it. So now we have this OPQRST. All right. And this is a second acronym here. And while samples for the history, we call it a sample history, right? OPQRST is to investigate pain. And that could be either pain from a trauma, like, oh, I broke my arm, or pain from like chest pain, like you're having a heart attack. Okay. So, onset, right? What were you doing when this happened? Oh, I was mowing the lawn. Then all of a sudden my chest was crushing me, right? P, provocation slash palliation. Two big words there, but think about the word provoke, right? Provoke means to make worse. So does anything make the pain worse? And palliation, does anything make the pain better? All right. Provocation, palliation. Oh, it feels better when I sit down, or oh, when I lift my arm up, it hurts more. Q, quality. Can you describe the quality of the pain? And again, sometimes we need to help our patients out with this. So is it a dull pain? Is it a sharp pain? Is it a crushing pain? Help describe that pain. Radiation. So does the pain radiate anywhere? And radiation means when pain moves from one area to another. And the classic one we think about is if someone's having a heart attack, sometimes they'll feel pain radiating from their shoulder down. Something else that can happen is like if you hurt your leg, right? You might have shooting pain down your leg. That would be radiation. Severity means on a scale of 1 to 10, give me a number. And this can be a little tricky sometimes, very subjective. I'm really weak, so I might say like, oh my gosh, it's a 10, but somebody else might say, no, that's a 2, right? So subjective, but you always try and say, if 10 really set the scene, if a 10 was the worst pain in your entire life, somebody was chopping your leg off with a dull spoon, what number to be? And then they usually go, oh, that's a 4, right? So yeah. And then T, time, right? How long has this been going on? Have you been nauseous for an hour, a day, a week, 2 weeks, right? The time frame. So that's history, right? Sample, which is the sample history, and OPQRST, delving more into that pain and figuring out what's going on. All right. So the next part of our patient assessment is the physical exam. And this is a systematic head to toe, hands on exam of the patient. And it's important to ask the patient for permission, which I know you did at the beginning, but ask again, hey, I'm going to just feel around for anything. You tell me if it hurts or not. All right. And you can see them, these guys in the snow here are doing that, right? He's here at the neck. One guy's stabilizing the head. This guy's working his way down. So when we're doing the physical exam, we're looking for anything that's wrong, right? We're looking for anything that's broken or doesn't feel right or causes the patient pain. And obviously, we're always going to wear our gloves and PPE when we touch the patient. All right. And we're going to do two things. We're going to look and then we're going to palpate. If you remember, we talked about palpate with B for breathing, right? OI pass in primary assessment, but we're going to feel. So look and then feel. And that doesn't mean just a quick touch, right? You really want to feel everything and see if you feel anything weird, which we'll talk about in class. We'll talk about this acronym DCAP Beatles here. That's what we're looking for. But you're looking for anything that's not normal or anything that hurts the patient. And again, it's systematic. So we always start at the head. So start at the head and real slow work your way down. Head to the neck, to the chest, abdomen, pelvis, groin, leg, arm, arm. We do it in a system so we never miss anything. And we go real slow because sometimes if we just go whoosh, right down the arm, we might miss something that hurts them. So we really need to go slow and systematic. So that's our physical exam. And then the last part here is vital signs, all right? And vital signs are key in evaluating the patient's overall condition. If you've ever been to the hospital or visited somebody in the hospital, right, you'll see every patient is always hooked up to monitors to monitor their vital signs because it is the best tool to see how well a patient is maintaining homeostasis internally, right? Yeah, we can look at somebody, we can palpate, and we can ask some questions, but somebody might not feel that bad, and then all of a sudden, boom, crash and die, right? Well, if we were looking at their vital signs, we would have seen that they were probably starting to trend down. So we always need to monitor our vital signs. And even like in that example from hospitals, on the floor of any hospital, right, the nurse's station is always in the middle. And if you ever are near there, look up and you'll see the TV screens. And it has every patient's vitals are in there. So they're always watching them, even if they're not in the room. And if they see something going down, they're going to go check on that patient. So those are what our vital signs are, right? It's the best way to look in and see how a patient's doing. And we should take these every 5 to 10 minutes to see how that patient is trending, right? That first set's called our baseline. That's where they start. And with our care, they're either going to go up or down. And it may not be because of what we're doing, just might be because they're so ill or so injured that they're going to go down. All right. So for a real critical patient, we want to take every 5 minutes. For a patient that's stable, we're going to do every 10 to 15. All right. And what are our vital signs? Whoopsies. Okay. They are level of responsiveness, right? Our pulse rate or our heart rate, our respiratory rate, how much we're breathing, our blood pressure, oxygen saturation, so how much oxygen is in your red blood cells, and that's cut off there, but it says temperature, right? Especially right now with COVID, that's a huge vital sign we want to monitor. And you don't need to know this chart right at the moment, but we'll go through this more in person when we practice, but there's normal ranges for these vital signs, right? So you'll see like for an adult, right, for heart rate, a pulse, you should be between 60 and 100 beats per minute. If someone is 140, why? We need to ask why they're doing that. We need to watch what happens with all these vital signs. Okay, so those are the 5 vital signs. We'll practice more of how to take these and what they mean in the normal ranges. But again, crucial to really do these often and to keep an eye on what's happening to the patient. And also really important to pass these along to the hospital because we need to let the doctor know what was happening right away when we first saw the patient and then what they look like now while we're at the hospital. All right, so then finally our last part here is kind of the reassessment or the ongoing assessment, we call it. And it's just important to remember that a patient's condition can and will change over time. All right, so during reassessment, we're going to check how well our treatment was, especially if it's an injury. Do we need to splint anything? Do we need to fix or change anything? You're going to repeat some parts of the assessment. So basically, you start over, right, and you're going to check ABCDs again. How's their airway? How's their breathing? How's their circulation? Then you're going to go back and do your secondary assessment. Basically, you go back to the beginning and start all over. And again, we already said check vital signs every 5 for unstable, 10 to 15 for stable. And with that part of that reassessment, you're basically doing your patient assessment all over. Go back to your ABCDs and primary assessment, looking for those life threats, and then monitor the vital signs. Okay. If that patient really starts to trend down, either in pain or in vital signs, consider what you can do to improve the situation. All right. Do you have ALS on route? Do you need to change which hospital you're going to get to the closest hospital? So, really always keeping an eye on that patient, because the worst thing you could do is do your primary assessment, do a secondary assessment, and then say, all right, I figured it out, and just leave the patient. And I mean, you're with them in the ambulance, but say, all right, they're good, and not really pay attention to them, go on your phone, talk to your partner, whatever. Then all of a sudden you turn around and they're dead because you were not continuously assessing them. So reassessment or ongoing assessment is really, really key. All right, so that's the end there. Go back through if you missed anything and fill it in. Feel free to shoot me an email or tweet at me at Mr. Toda13 if you have any questions. And hey, smash that like button, subscribe, and we'll see you on the next one.